Good morning. I'm Dr. Sean Coomer, Chief Medical Officer at the University of Kansas Health System. This is Open Mics with Dr. Coomer. Today we are talking about Tommy John surgery, and it's no longer just a problem for the pros. Tommy John surgery is a procedure that rebuilds a torn ligament in the elbow called the ulnar collateral ligament, or UCL. It's a key stabilizer for throwing anything, including a baseball in this case. UCL surgeries in young athletes have jumped more than 300% in a decade. For sophomore pitcher Daniel Haivala at Mid-America Nazarene University, a bullpen session turned and changed everything for him. He found himself facing one of the most talked about surgeries in sports medicine. Alexis Del Cid shows us.
Of all the places Daniel Haivala envisioned his baseball career taking him, this was the one place he never wanted to go. But when he learned he had to have this surgery, Daniel absolutely wanted this surgeon. We'll get to what Dr. Vince Key and his team are doing to put Daniel's elbow back together in a moment, but first the injury.
The second I let go of the ball, it snapped, and I heard it. My pitching coach heard it and everything.
A sophomore at Mid-America Nazarene University, Daniel pitches for the baseball team. When he was growing up, his grandfather and mentor, who happened to pitch for the Kansas City Royals back in the 60s, always stressed the importance of protecting his arm.
My grandpa hated off speeds. He hated throwing curveballs, sliders, anything like that, because he knew that it was stress and tension on your arm.
But by the time Daniel was playing, times had changed.
Modern day baseball, sweepers, sliders, curves, those are like some of the main pitches that people throw now.
And Daniel was practicing a new curveball when life threw him one.
I heard the elbow pop.
An MRI at the University of Kansas Health System confirmed Daniel had the very injury his grandpa had always warned him about. His ulnar collateral ligament, known as the UCL, had torn. The UCL is what stabilizes the elbow during throwing motions.
Then when my grandpa used to play, that's career ending. Like, you're done the second that you hear that.
Luckily for Daniel, times have also changed in this regard. This injury no longer has to be a career ender.
Incision will be here, here, and here.
Dr. Vince Key is the head team physician and medical director for the Kansas City Royals.
He's got a good track record.
He also happens to be the University of Kansas Health System orthopedic surgeon about to perform Tommy John surgery on Daniel. It's something Dr. Key says he's done for around 500 patients over the course of his career.
Dr. Key, he's very, very specific in elbow surgeries and studying elbows and everything like that.
To do the surgery, Dr. Key uses a technique specially designed for pitchers. First, he removes a tendon from Daniel's forearm. It will replace Daniel's torn UCL. And yes, that's a drill Dr. Key is using. He's securing that tendon into Daniel's bones by drilling small holes into them and threading the replacement through those holes to anchor it.
Now, we're gonna let it go, let it go. It's gonna ache. Yeah.
A few weeks later, we catch up with Daniel, who's in a bit of discomfort, but he knows it's temporary.
Right now, obviously it sucks because I'm in pain, but 99% of the time you're good to go in 10 months to a year.
He plans on being diligent with his rehab and physical therapy to ensure he's back on the mound next season.
Joining me today is Daniel Haivala. It's great to have you today.
Happy to be here. Thank you.
Also joining us via Teams is Kyle Veazey, a physical therapist here at the health system, and orthopedic surgeon, Dr. Vincent Key. Dr. Key also happens to be the head team physician for the Royals and has spent some time in Surprise, Arizona in spring training, which is about to break here as we hit the opening day in Atlanta, I think, on Friday. So I want to start off with Daniel first. How is rehab going for your arm so far?
Yeah, rehab's been going great so far. I'm probably at about week 7 after my surgery, and I've got full extension, mobility, and everything like that back in my arm. I just obviously don't have the strength that I used to before I tore it.
Yeah, it's a tough one. I know my pitcher nephew went through this just about a year ago as well. So I'm glad you're doing well so far.
Thank you.
Kyle, is the rehab process the same for everyone when recovering from Tommy John?
early stages of rehab are going to be the same. So there's biologic and physiologic principles. We want to get the swelling down, protect the incisions regardless of what type of graft that Dr. Key used. And then we want to get their elbow straight. So restoring elbow extension is our main obsession these first early weeks after surgery. But usually after, about a month out, guys start feeling really good. The problem then is keeping the reins tight and not letting them do too much stuff. So we keep them in the brace, unlocked, but we keep them in the brace just to be in that max protection phase. And then once they get closer to 2 months out, then we're starting to build some early strength and really starting to work on some capacity building for their shoulder and scap. And really, the other big important thing is we want to work and look at their total body. So a lot of times in this first couple months, as a guy's had this Tommy John surgery and UCL reconstruction, we might be doing a lot of lower body stretches and hip mobility and working on their hamstrings and working on their ankle dorsiflexion, because that's maybe some of the reason that they ended up needing to see Dr. Key or getting in the OR. So early stages, the principles are the same, and then we kind of tailor it to the individual athlete, whether they're a collegiate pitcher or a high school athlete or they play a different sport. We're going to tailor it to them. But early on, we want to get the swelling down, get the elbow straightening, and then we'll go from there.
So you're working on range of motion first and then strength as the time goes on. Yeah, I think
That's
a lot
right.
of people don't realize that, pitchers use their legs tremendously, and they need to be strong. It's not just all about the arm, of course. So, Dr. Key, when Daniel heard that pop, what is it? But everyone thought, immediately Tommy John surgery. What are you looking for clinically before the MRI even confirms that?
Well, I think a lot of it is just the history of the patient, right? Daniel felt a pop. That's not usually, I shouldn't say usually, but most of the time they'll feel a pop, but sometimes they don't. And it can be really insidious in onset. The integrity of that ligament, to me, is based on two things: command, being able to put the ball where you want to put it, and then velocity. And, I get guys in here that throw 94, 95 miles an hour, and then all of a sudden they have an issue throwing, and now they're only throwing 83 miles an hour. So it comes in various stages and how it presents. But usually if you feel a pop, it's usually something pretty catastrophic. And there's different tears, if you will. There's different grades of tears. Just because you have an ulnar collateral ligament tear doesn't necessarily mean that you're going to need Tommy John surgery. Because I see plenty of guys who have small tears, their command and velocity are good. And a lot of times, just like Kyle said, it's cleaning up the other things. The elbow is a victim of everything else not being right.
So, Dr. Key, what exactly is happening inside the elbow when the ulnar collateral ligament fails?
Well, when it fails, it's basically stretching to failure. It's the collagen. It's all of that. It's just like taking a rubber band and you're stretching it and stretching it. Every time you throw, that ligament stretches. And it's a micro trauma, if you will. And I akin it to, you only have so many clicks in the elbow. And you get to a point where you throw one time and it just fails and snap. It just goes.
Gotcha. All right. Kyle, I think you mentioned a little bit of this earlier, but when you first meet a Tommy John post-op patient like you've seen here, what's your number one goal in the early weeks?
The first goal is, number one, to get to know them and kind of build that therapeutic alliance and understand what's important to them and what their goals are to get back to sport. The other thing that's really important early on, especially with higher level athletes who are undergoing Tommy John, is setting some realistic expectations and letting them know that it's very normal in the first couple of weeks to have soreness in your arm, and we're going to be working on range of motion. But the early emphasis outside of getting to know the athlete to provide some tailored treatment is really getting the swelling down, protecting their incision, watching the incision, and then getting that elbow range of motion. And in particular, we got to restore their pre-surgery levels of extension. And that's based on their own anatomy, that's based on their history, because some throwing athletes who get to the collegiate level, in Danny's case, maybe they weren't at full elbow extension to begin with, and then other athletes might have hyperextension of their elbow. So then it's a conversation with Dr. Key to figure out, okay, on this particular athlete, how much extension do we want? What's our goal for the range of motion? But the early stages, we got to get the swelling down, and we have to work the elbow extension.
Gotcha. So Daniel, you were getting ready for your season, just like the Royals are planning to start here soon. Can you take us back to that bullpen session and take us through it?
Yeah, so it was right over my winter break and everything, so I didn't have any of my college coaches with me or whatever, so I was back home at my normal pitching facility for over the summer and off season, throwing a normal bullpen session and everything like that. I was supposed to go 25, 30 pitches. I got probably about 20 pitches in, felt great, body felt great and everything like that. I wasn't under any soreness, any pain or anything. Started ripping a couple curveballs. Third or fourth curveball that I threw, I felt a pop in my elbow. And kind of looked back at my coach. He heard it and everything like that too. Instantly told me to stop throwing the ball and everything like that. I thought, my body might sometimes do that. So I kind of wanted to try and throw one more pitch. And I convinced him enough to let me do that. And I threw it straight in the dirt. It maybe went about 40 feet in front of me. So
yeah. So just like what Dr. Key was saying, command and velocity. And you knew right away. So that's tough. So you're a sophomore at Mid-American Nazarene, just a few months out, or days out from baseball season now. What were you thinking about this coming season? Or did you know and you'd be out for this season?
Yeah, so I basically knew, especially right after the MRI, that I was going to be done at least for 2 to 3 months if I didn't know that it was fully torn. But now that I knew it was fully torn, I knew I was going to be out for the whole season, for starting the summer with the rehab program and everything like that. So I'm looking forward to getting built up for my junior year.
Gotcha. Dr. Key, we're seeing more high school and college athletes with this injury. Are arms simply throwing harder, or is something else driving that increase?
Well, I think it's a little bit of both. I think kids, honestly, are overworked and undertrained. We're all about throw. We're about spin rate. We're about velocity, things of that nature. And again, there's only so much stress that you can put on an elbow. So when you throw, like I said before, it's a click. Well, if your kinetic chain isn't right, your posterior capsule of your shoulder is tight, your scapula doesn't work very well, your core is bad, your lower half is bad, well, every time you throw is not one click, it may be 2 or 3 clicks. And like I said, you only have so many in the elbow. So you're seeing this, kids are playing a lot of baseball during the summer. They're playing, 70, 80 games. They're playing multiple games in a weekend. So again, there's only so much that you can do. So I'm really big on prehabbing these kids, meaning they have to get their bodies ready to withstand what you're asking your body to do. And if you don't, there's a chance that something could happen. And unfortunately, then you're talking about surgery. Hopefully not. There are partial tears, like I said, that we can use biologics, what's called platelet-rich plasma, or PRP, and then shut them down, clean up their kinetic chain, and then hopefully they can continue to pitch. And that's what Daniel was hoping, but he had kind of a catastrophic injury to that elbow. So surgery is the next option.
Yeah. So Daniel got in fairly quickly. For families watching, how urgent is the evaluation when a pitcher feels that kind of pain?
Well, I think it's important in terms of the evaluation. It's not life or death, obviously, but I think it's such that you get in and you get evaluated. And again, it's asking the questions. Like I said, how's your command? How's your velocity? Daniel tried to throw the The time after that, he threw it right in the dirt. And so you can kind of get a sense of kind of what you're dealing with just based on asking certain questions. And then at that point, you get to scan. You see the scan, what type of injury is it? And then lay out the treatment options. It's kind of one of those things where most of the time when I'm examining them, I examine their elbow last. I'm examining their kinetic chain. I want to see what that is first. And then we get to the elbow. So once I establish that their kinetic chain isn't very good, then we send them to Kyle or send them to our other therapists to start getting that dealt with. And then on the other side, we're dealing with what we need to do with the ligament.
Thanks. Kyle, parents often assume rehab means just rest. Now, you obviously described some of the relationship building and therapeutic relationship you developed with Daniel, but what happens during structured throwing rehab?
Just as we've been talking about, I think a lot of current ball players and their families or parents or even coaches, we don't appreciate all the demand that the muscles, the tissues, the body is going through in order to play baseball, let alone pitch at a very high level with maximum effort, with max speed, and we're chasing velo, and we're trying to throw as hard as we can and be as consistent as we can. A lot of amazing things need to happen in the body to be able to do that. But that means that the stuff that helps us start and stop that motion at the shoulder, at the core and the trunk, at the hips, at the ankle, everything's got to be working. Everything's got to have enough capacity and muscle strength and muscle power and muscle endurance to be able to perform, to be able to do that. So a lot of times our rehab, the early stage, once we get out of that protection phase and then we go to the next phase where maybe now they're like 2 to 5 or 2 to 6 months out of surgery, and now we're really working the entire body to build capacity. Once they start their throwing program, then we're still going to work the lower half. We're still going to work trunk and neuromuscular control exercises that can mimic or help us kind of set the table to get ready to throw. And then even as they're into their throwing program, which is typically 3 days a week, once they've earned the right to start a rehab throwing program after their Tommy John surgery, we'll throw 3 days a week, but then the other days they have homework. They have continued maintenance work to do, or they have continued exercises to do that might be a lower body day, or it might be more like motor control exercises. But the rest is not like let's lay on the couch for 2 weeks or just play video games and don't do anything else physically active. It's actually like we got to work everything else and protect the elbow. So it's really active rest is what Dr. Key likes to call it.
Okay. So I think you mentioned some of these, but that's sort of how you balance protecting the graft while also preventing stiffness or weakness?
Yeah, exactly right. We want to, there's a fine line. I'd say that's one challenging part of my day-to-day job is balancing the line based on how their arm and their elbow are feeling. I want to restore motion without allowing too much stiffness to set in. However, we have to protect the graft that was just reconstructed. So there's a fine line there, but that's why we use a combination of treatments. And some athletes need a lot of manual therapy and soft tissue work and joint mobilization and different forms of manual therapy and range of motion. Other athletes, their motion comes back no problem, and then we can work on other things. So that's where we kind of tailor the treatment, but it is a balance of wanting to restore the motion without overstressing the newly reconstructed graft.
Okay. Daniel, what concerns did you have with the injury, and why did you seek out Dr. Key?
Yeah, so my main concern was I'm going to be out for the entire season. I kind of knew that was going to happen, and so the main reason that I was trying to seek out somebody that's a great professional like Dr. Key is because he has a great track record. I know that he was the Royals' main team doctor and everything like that. So I pursued him because I knew that he could just like keep everything in line for us and everything like that. He had a great track record. He's done this to people a lot of times before. So I knew that he's the right guy to go to and to follow.
Yeah, I agree. Also, when did you know you wanted to be a pitcher and also pursue it beyond high school?
Yeah, so I actually didn't know that I was just going to be a pitcher until last year, because I signed to Mid-American Nazarene University as a two-way player, so I was going to be hitting and also playing third base as well while pitching. But I threw a couple of bullpen sessions, and they instantly took the bat out of my hand. They forced a glove into my hand, and I haven't been able to swing since.
Dr. Key, Tommy John surgery is becoming a very common surgery, with some research suggesting more than 1 out of every 4 professional pitchers will at some point have this surgery. Is this rinse and repeat? Does every surgeon do the surgery the same way?
No, they don't do them all the same way. It's gone in an evolution. And Dr. Joe, who actually invented the procedure itself, I had the pleasure of actually being the last resident to work with him. I trained in Los Angeles. And so there are some doctors that are using the patient's own tendon, and then they put what's called an internal brace in, which is basically a strip that's partially made out of Kevlar to reinforce the graft itself. Me personally, the technique that I do is a different technique. It's a hybrid technique. It's honestly, it's probably the strongest construct out there. And most of the time when most physicians are using what's called the docking technique, they're using 2 strands of the patient's own tendon and then using the third, the tape as their third strand. I do a triple loop technique, which is different. I take the patient's own tendon and I fold it back on itself in a 3-loop technique. And then what I do is take the patient's own ligament that's damaged and weave that in to the reconstructed ligament. So it's almost a 4-ply technique. And I've been doing this probably for about 16 years. I've done probably over 500 of these. I know I've done over 100 in the Royals organization, and I've only had 2 failures that I know of. And these grafts that I use tend to last longer. We talk about in the industry, because we have a lot of high velo guys that are throwing routinely 95 to 100 miles an hour, that these grafts only last 3 to 5 years, maybe up to 7 years. Well, I can tell you, in the World Baseball Classic on Team Venezuela, one of our former players, he was one of their setup guys, and he was throwing 97 to 100 miles an hour, and I did his Tommy John surgery 11 years ago. We have a pitcher on our staff now in our bullpen that I did his Tommy John surgery 13 years ago. So these grafts are holding up. My technique is holding up. Unfortunately, we need something like this technique, because unfortunately kids are getting these procedures younger, and it's going to take them a while. There's not a lot of pitchers that are going to jump. There's not a lot of Paul Skeens that are going to jump from, pitching at LSU to all of a sudden being a monster in the big leagues. So these grafts have to hold up.
Yeah. So we're here to answer any of your questions. Please send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. Let's check in with Doc Hawk. We're getting to the end of the respiratory virus season. Can we say we are almost done, or where are we?
Yeah, I mean, first of all, I like to say I always love listening to Dr. Key. Big brain on Dr. Key. Always doing good work. So thank you for being out there and doing all that stuff. Yeah, again, typically April 1 is when respiratory viral season ends. Typically it goes October to April 1. So we are nearing the end, thankfully. But more importantly is really how much of those viruses or how much spread is out there in the community. Overall, we do continue to have decreasing rates of evaluation for ILI, or influenza-like illness, in the hospitals and clinics and emergency departments throughout the country. So overall, I think nearing the end of this respiratory season, viral respiratory season, is a good thing.
So CDC estimates for this year's respiratory viral season to have seen 28 million illnesses, 360,000 hospitalizations,
Yep.
and 22,000 deaths from influenza this season. Unfortunately, we have seen at least 115 pediatric deaths, with 14 reported in CDC's flu view this past week.
Yeah, and I think that is unfortunate. Anytime we have any death, and especially any pediatric death, that's a horrible thing. I would say, throughout the country, we have seen decreasing rates overall in our health system. We have also continued to see decreasing admissions for respiratory viruses. We have 5 admissions for influenza, 9 for RSV, and 11 COVID. So COVID has kind of overtaken as far as admissions. It's still low, but remember, COVID cases overall most recently have been quite low. And 11 COVID cases here, and we are seeing, unfortunately, some mutations that are concerning around the country as well. There does seem to be a highly mutated SARS-CoV-2 variant called BA.3.2 variant, which has been circulating at low levels in the United States. Again, it's not new. We've known about it in the United States since June 2025, but we have seen increasing levels in parts of Europe as well. And the concern is that those significant mutations, numbering about 70 to 75 different sites on the spike protein itself, and if you remember, the vaccine is directed against the spike protein, so there's concern that there could be immune evasion from that immunity that's provided only by the vaccine. But we do know and understand that with people being vaccinated multiple times and probably infected multiple times, you also have that other immunity from that infection, which is not just a spike, but other parts of that virus as well. And so we know that we continue to overall have population immunity. We also have individual immunity. And right now, that variant does not seem to be causing any more severe disease. So that is always a good thing.
So this has obviously increased a little bit as far as the COVID, but people have been vaccinated. There's some herd immunity that also the revaccination rates have, kept us a little bit healthier.
And I would say that as we're talking about vaccines now, just like you said, with the repeated infections and vaccines, there was a recent article in PLOS Medicine that actually showed that the risk of sudden death of young people and adolescents was decreased with the COVID vaccine, or there wasn't any risk of sudden death in those people that got vaccinated, especially the younger population, where overall sudden death in that population is very low anyways, but there did seem to be a significant decrease in a chance of sudden death for that. So, and this is only to point out that we know and continue to understand there are concerns about safety of vaccines. This is one of the most trialed vaccines ever, specifically the COVID vaccine, but also it's been used so much. It has an excellent safety profile, an excellent safety record, and there continues to be further evidence and data, real-world data, showing very good safety profile. And just as we are talking about vaccines, we should note that there has been changes to ACIP over this past year, which is that recommending body for vaccines. Just yesterday, the vice chair of ACIP did resign, and we should note also that last week a federal judge, basically with all the changes that ACIP made, the federal judge had said that basically those changes are null and void at this point in time. All those previous vaccine recommendations that were changed are null and void. Basically said the current ACIP group does not have the expertise to make those vaccine recommendations. Obviously, we know the government will appeal that. So, but for right now, going back to the original vaccine schedule, which is a good thing, and we'll see ultimately what comes up. The biggest thing is, Sean, and and I know, it's really just to help keep people and their families safe, understand what interventions are we giving, what medicines, what is the safety profile. First, do no harm. We know that these vaccines have a great safety profile, so we will continue to report on those updated statistics and go from there.
Great. Thanks, Dan. I appreciate it. Yeah, thanks about mentioning the ACIP thing, because that was a new development, and obviously the changes to the vaccination schedules were quite drastic several months ago.
For sure. And I think a lot of people were mostly concerned because once ACIP makes these changes, there's concern about being able to get those vaccines paid for. We know it's very hard time economically and with health insurance, and so we want to continue to let people have access to adequate medical care and preventive services as well.
Great. Thanks, Dana.
Thank you.
We know many of you have questions, so let's head to Studio B with Alexis.
We have a great question from Jill. Jill wants to know, if you only have so many clicks in your elbow, as Dr. Key said, is it inevitable that an aggressive pitcher will eventually have to have Tommy John surgery or some kind of repair?
Dr. Key, do you want to take that one?
Yeah, not necessarily. I mean, the body is an adaptive thing. And so just because you throw hard, again, doesn't necessarily mean you're going to go down that road. But if you can keep your kinetic chain good, the chances of injury do go way, way down.
Okay. Well, we want to go ahead and get some final thoughts from folks out there. Dr. Key, do you want to kick us off?
Well, I think the biggest thing, thanks, Sean, and shout out to Dana. I love Dana. Dana is the man when it comes to ID and all the good things. I think the biggest thing that I always tell parents is that, number one, let your kid have fun. Number two, again, prehab so we don't have to rehab. And the thing is sometimes more is not better, smarter is better, be efficient with what you do. But if something happens, okay, we treat it, just like Kyle said, we do active rest, and the things that we teach them to do, they continue forward, like I said, and give these kids a chance to go out and do the things that they love to do.
Good advice. Kyle?
I would say for any younger throwers, whether they're adolescents or at the high school level, learn to move your body, learn to have control of your body. You're asking it to do a lot at high speeds whenever you're pitching and playing ball, but have fun. But also let's not forget the lower half of the body, the core and the trunk, because all those things will help your arm function better and keep you healthy.
All right. Daniel, we'll get your last word.
Yeah, so finally for me, I'd just say that know your body. Know everything about your body. You know your body more than your coaches do. If you're in pain or anything like that, let them know. Tell them where it is, and then they're the professionals. They can tell you what's wrong with yourself. That's why I seeked out Key and Kyle, because they are the professionals in the business, and I trusted them with everything going on in my rehab, and I'm just trusting the whole process with how it goes with them.
Yep, they are the pros, that's for sure. Let's check in with Alexis one more time to see what she's covering for tomorrow's All Things Heart. Alexis?
Good morning, Dr. Coomer. We have a great show tomorrow. It's about a woman named Alicia Smith. She lived her entire life thinking she had a disease that was so rare, she and her mom were among the only people in the world to have it. But then cardiac genetic testing here at the health system changed everything. So tomorrow we explore cardiac genetic testing, what her testing revealed, and how it's helped shape the care that Alicia and her mom are getting. That's tomorrow at 8 a.m. on All Things Heart. Back to you.
Thanks again to all of our guests and to our audience. I'm wearing green today in my tie because we're having a magnet announcement today, and we're 100% behind our fantastic nursing team. Remember, faith, hope, and science.
Subscribe to our morning medical update and open mics with Dr. Stites podcast. Now everywhere podcasts are available.